For those of you who don't know me, I'm Jarrett Helming. I'm one of the orthopedic surgeons here. I've been here since November 4th of 2013. So we started at the beginning of the year. We've got, I think we're up to 10 anterior hips now. Everyone seems to be doing great. My claim to fame right now is my first 3. None of them took one pain pill. Tony, if you guys ever come to our office, Tony is my PA. She's actually been a PA longer than I've been a surgeon in orthopedics, so she's great. So sometimes you'll see me, sometimes you'll see Tony, sometimes you'll see both of us. And then we have a bunch of other staff members that will, be your guides to this process if we decide that hip replacement's for you. I describe arthritis as a road. And when you're born, the road is brand new. It is newly paved. There's not a crack on the road. You are just flying like the wind. There's no bumps below you. But as we age, the cartilage starts to wear down a little bit. It starts to crack. Yeah, you can still go pretty good, but there's not really anything getting in your way. But there's starting to be some wear on the road. And eventually, water can get underneath those cracks. Just like in a road, you can get potholes, and then you miss chunks of cartilage, and your body starts to say, hey, I need to fix that. That causes inflammation, that causes swelling, that causes pain, that causes all of these symptoms. This, I think, is a big one, right? I always tell people I don't want to, I'm not in this to like save lives. I'm in this to just keep you in the game or improve the quality. This, starts to get real. I see a lot of people that are not as active as they want to be, or they've gained weight, and because they've gained weight, now they can't be as active, and it's just this revolving door, this never-ending cycle. So arthritis, like I said, it's the leading cause of disability in the United States. 50 million American adults in the United States are diagnosed. That's 1 in 5. To be honest with you, it's probably even higher than that, but other times, other diagnoses outweigh the diagnosis of arthritis. How do you diagnose it? Usually in our office, X-ray, CT scans, MRIs sometimes are necessary, but not usually. Laboratory tests, that would be for the stuff that would affect multiple joints, rheumatoid arthritis, lupus, psoriasis, all those different, there's 1,000 types of different arthritis, but this is where this would come in. Osteoarthritis is what the main cause is. That's what you're gonna call your wear and tear arthritis, or just, joints wearing down here. This is, again, like I said, women, honestly, almost as much as 8 times as likely to develop hip arthritis. Recently, knee replacements, about 600,000 are performed a year, with that number expected to increase by 25% in the next 10 years. So it's just as the baby boomers continue to age, we're seeing that percentage on the rise. And then hip arthritis, specifically for women, almost 40% higher than men, and that plays out of the 350,000 hips done a year, 230 of them are women, and these are just most recent studies. So, why does my hip hurt? Kind of talked about that a little bit before. The difficulty with the hip is the location, specifically in women. You start talking about hip pain. Most people are like, my hip hurts, and they're pointing here. That's not the hip. That is the bursa, right? That is the inflammation. That's your IT band. But that is a direct cause of the actual hip arthritis. Your ball and socket of your hip replacement is actually right here, is your groin. Groin is actually, when I do surgery, that's where I am, right in there. That's where your hip replacement is going to be performed if you need it. Again, just the analogy of the road, bone on bone. This hurts. The body thinks, hey, I can fix this, and I know how to fix this. I'm going to fix this by growing more bone, because if I'm running out of bone and the bone is now exposed by growing more bone, I can offload the pressure, and that's going to help. We call those bone spurs. No. Great thought. It's one of my questions I have for him upstairs when I get there. It just doesn't quite work out that way. So people think that your bone spur hurts, and I just need to get rid of my bone spur. The bone spur is the result. And until you take care of the underlying problem, the bone spur, you can get rid of it all you want, it's just going to come right back. So treatment options. So obviously when we start talking about, are you a candidate for hip replacement, I'm always going to harp on these 3 things. If you've ever seen me in the office, I almost always will give you 4 options for any diagnosis that I give you, and the first 3 are always going to be conservative options, and the 4th one's going to be surgery. And so we're going to harp on exercise, we're going to harp on diet, we're going to harp on, you know, maybe injections and therapy programs. We're going to talk about activity, finding that middle ground. Too much activity is going to cause pain. Not enough activity is going to cause weakness. You need to find that middle ground. Unfortunately, that jumps around a lot and it's kind of hard to find, but you know, that's what we're going to try to stress at first. This just makes us look a lot cooler than we are. And this is actually for my knee replacement. This is the robot called Rosa. She's fickle, but she's pretty nice. And then these are just all the different options that we do. Today, we're here to talk about the anterior superior approach, or the anterior hip replacement. Anterior is a word that simply means the front of you, right? So this is anterior, this would be posterior. So typically there's 3 ways to do a hip replacement. There's anterior, which would be my incision is about right where your pocket is, which is the new way we're doing. The way I also do it still is the anterior lateral, which is just a little bit on the side, but in the front, we go through there. And then the other one is through the same type of incision, but it's through the back, called the posterior approach. A lot of times you talk to your surgeon, you're gonna find that it's all just personal preference or how you have been trained. There's a lot of talk about the anterior spine approach, or supine approach, which we'll talk about as to why are the advantages on the front end, right? And that's really where you're going to find the advantages, on the front end, which, to be honest with you, that's what people care about, right? They care about the pain when you recover right away. They care about the when can I do things. Statistically, at 3 months, though, no matter how you do it, lateral, posterior, anterior. At 3 months, statistically, all the patients are pretty much the same, right? But there is much more recovery or faster recovery with this approach on the front end. So considering hip replacement, obviously we're talking about surgery, and it's a pretty big surgery, right? You go completely to sleep for this. There are risks. Average risks factor is somewhere around 1 to 4%. Obviously, we can make your risks higher with 2-pack a day smoking, uncontrolled diabetes, morbid obesity, not a good diet, and just other medical comorbidities like your heart issues or lung issues, stuff like that. But the big things I talk about with people about the hip replacement is, listen, we've kind of perfected how we do this. Not me personally, just the guys before me, and they kind of taught us all how to do it. But you're always going to have a risk of infection, blood loss, nerve damage, anesthesia complications, continued pain after surgery, need for more surgery. These are the big ones, right? Again, rare, right? 1 to 4%, but they're all still always going to be there. You can't make these 0. But low. I mean, that's a really good statistic. So let's go on here. Hip replacement is, and maybe I'm a little biased, but hip replacement surgery has the highest patient satisfaction outcome of any surgery ever performed in the United States. Meaning, people like their hip replacement better than their open heart 4-vessel cabbage that literally saved their life. We're not saving lives here, right? But we think this is because specifically hip arthritis is some of the most painful arthritis of any joints that people experience. Again, we have no idea why. This doesn't make sense to us. You're putting the same weight on your hip than you are your knee, than you are your ankle. It doesn't make sense to us, but that is true. So when I joke around a lot, but what I always tell people is, man, we could put this thing accidentally backwards and upside down and you'd probably still love it because your arthritis is gone, right? And your body is going to heal, and you're just gonna, once you get there, your body's just gonna, you're just going to be back to normal, and that's the goal with this surgery. Yeah, so 350,000 hips done a year. Some estimates as high as 450,000. Again, 25%, I can't do the math, whatever, 25% of that, add on to that would be what, another 100,000, 110,000 more. So we're close to $600,000, 600,000 performed every year is the estimate as we keep going. Yeah, so this is a cool stat. People always want to know, am I too young for hip replacement? Am I too old for hip replacement? Statistically right now, between 80 and 95% of the total hip implants that we put in are lasting greater than 20 years. And so a lot of times people come in, 60s is pretty average. And so we're telling people, hey, hopefully this is gonna be it. And this is based on, this 20 years is based on use, right? So when they test the implants, I got a bunch of implants there if you guys wanna look at them. We test them in a lab at 250 pounds for 3 million cycles, which is a fancy way of saying steps. So we look at the wear patterns and how long they're lasting. So if you weigh less than 250 pounds, it's probably gonna last even longer. But the 1 ounce over 250 pounds, I have to tell you, I don't know. It could be 10 years. It could still be 20 years. It's just they don't test above that. So we hope it's still 20 years. And then I always tell people, if you're worried about this, come talk to me in 20 years if it even bothers you, right? Don't worry about that now. Worry about that in the future because you probably don't even have to worry about it. So a lot of options for implants. I have the implant that I use a company called Zimmer Biomet. Specifically, the hip that I use is called the Dual Mobility Hip System. The reason I use this hip system is truly I think it's the best hip on the market. It's the most widely used hip on the market. It has a larger ball on the head, on the ball and socket part. It also has a ball within a ball, so it has an extra joint or mobility. Why I think this is better is because it is the hardest hip to dislocate, right? That's one of the biggest fears is dislocation after you do the surgery. So it's one of the hardest hips to dislocate, and it has the highest range of motion. So to restore, the hip is a circle, right? So you can do a lot of cool things with your hip. So the more I can stabilize that to allow you to do those things, this is why I choose. So the metal is what most people get, which is a metal ball inside of a plastic container inside of a metal cup on a metal stem. The pink is ceramic. So ceramic is the longevity. It lasts a little bit longer than the metal. The problem with ceramic is it's wickedly expensive, and so we reserve the hip replacements, and so do the insurance companies, reserve those for our younger patients, our post-traumatic hip replacements in their 40s and stuff like that, to see if we can get them even more than 20 years. And so that's the difference there. Traditional surgery, so this is the posterior approach or the anterior lateral approach. Incision's usually about 8 to 10 inches. The difference between I don't want to say old and new, but the outside and the front is that to do the number one, which we still do and still get great results, is I do have to peel muscles off and reattach muscles in those approaches. And that is why the recovery on the front end of the first 6 weeks, it is a little bit more painful. There's a little bit more restrictions. If you talk to people, they had to sleep with a pillow between their leg and they couldn't cross their legs for 6 months and they can't kneel down and they can't squat. Well, we still don't want you doing a lot of those things. No matter how we do it, these restrictions are more important on the other side, the outside things, the outside approaches, excuse me. Leg length is a big thing. People always get really excited about, oh, my leg's longer now, my leg's shorter now, my legs aren't even. Two things I would say about that. Number one, they did a study that it's either 87 or 89% of people don't have the same leg lengths anyway, but you don't know it. And then someone makes you aware of it. And so we're chasing our tail here, right? But the big advantage of the anterior approach, which we now do, is during this approach, part of the way that we do this is I have to use X-ray or intraoperative X-ray. And because of that, I'm able to just move the X-ray over to your other hip and look at that one, and then bring this one back, and then bring it, and then I can adjust the leg length while I'm staring at it, and our chances of having symmetric leg lengths are higher with the new approach. So, anterior. So, incision is smaller, right? So it is in the front of your hip. Literally, it's that button that you can feel. That's called the ASIS. Your incision's about right here. We make it right over this big muscle called the tensor fascia, right over there. Why this is different is because when we do this surgery, all I'm doing is moving things out of the way, right? So I don't have to cut anything. There's intervals in there where I'm literally just pushing things out of the way. So I'm not disrupting any muscles to do the surgery. All I'm doing is I'm opening up the hip, right? You still have to do that to do the surgery, and don't Google it. Seriously, don't watch videos. You'll never have surgery. You can watch it afterwards, but do not watch videos. My wife and I, we both think that what each other does is really, really gross. Like, she does a lot of stuff here, and she's like, you're a sterile carpenter and you're using hammers on people, and that's gross. And so, like, just don't watch it. Again, the advantages. Through the anterior aspect, we have less dislocations. I can check the leg length during surgery. So before we leave, we have X-ray to prove that when we left, your legs were the same length. Because of the table, I'll show you a picture of that in a second. Again, don't watch the video. But because of the table, I have the ability to, in live time, I have the ability to take your leg out of the table, and I can move it around in surgery to make sure that it's stable before we even leave. And so it's a huge advantage that you can't do through the other approaches. So this is just, traditional on the outside, anterior right there on the front. The way Tony and I do the surgery, I don't use stitches, and so you are completely glued shut, so you are waterproof. So the next day you can shower. In fact, I encourage you to get in the shower the next day, wash. There's just a piece of mesh glued to your skin that we take off in the office 2 weeks later. The only rule is don't put lotion on the mesh. That peels it off, so just don't do that. But overall, we're really seeing good results, even though I did these a long time ago in my residency, and now we're getting back to it. And since this year, the ones we had, we're just seeing really a lot better results on the front end. These things are real. I think expectations, we have to do a better job at meeting the goals of the patient, right? And so I think that this is what the consultation for in the office is the best for. What do you want to do? What are your goals? What are your hobbies? I have people that we've done hip replacements that are still doing triathlons, right? You know that going in, and you treat them accordingly. The hardest patients to do the ASI approach on are obesity, and that's mainly because of you're laying flat. We just don't want to make sure your belly's out of the way. So as weird as it sounds, if your belly's in the way, we just tape it out of the way, right? So it's not a reason that you can't have surgery. It's just it does make the surgery a little bit more difficult to do. Body habitus, specifically, the hardest hip to do through the front is a very strong muscular male, just because the muscles are strong and they're big and they fight. Right? And so those are the hardest ones to do. Again, does not preclude you from having surgery. So again, this is the company that I use, Zimmer Biomet. Again, this is the stem that goes down the femur, holds the ball. This is the cup that is put into the pelvis. And then these are the two balls that kind of rotate on each other. I don't know if you guys can appreciate this, but I'll show you. So this is actually, let me show you this one. So this is the exact stem that I use that goes down there, and then the ball goes on the cut on the stem, and then this ball rotates around the ball, but then it goes inside of the cup and it rotates in the cup too. So look how much movement I can get by doing this. Recovery, I tell people all the time, my staff specifically, that I know how you're going to do with your replacement before I even do it, because the motivated succeed and the unmotivated don't. If you want to be a martyr, you're going to be a martyr, and you're not going to get good results, right? If you want to get up and get going and don't have to have anyone take care of you, you're going to do great. Like, that's just, it's true. But all of these things help you succeed, right? I think our hospital does a fantastic job at doing all of these things, right? Home health comes to your house for the first couple weeks, so you don't have to leave the house. Then we get you to outpatient therapy. They're great. Therapy helps you in the hospital if you spend the night. You don't have to spend the night anymore. We can send you home that day. A lot of people are just going home. We do surgery at 7:30, you're home by 3. So we're seeing that. Don't get me started on insurance companies. They're wanting to see that as well, and so that's another driving force. That's not the reason I'm doing it, but that is a reason why you're seeing it more and more often, because you're going to see more replacements done at surgery centers because insurance companies have found out it's cheaper for them. And so maybe not best for the patient, but cheaper for them, and so that's what you're seeing. I am doing about half of the ones that we've done already have been same day, and they've gone home that day and they've all done great, but I don't push that. You can, the majority of patients still stay 23 hours. We do surgery, you go home about 3 o'clock the next day. Wound care, this is all about diet, this is all about hygiene, this is all about keeping clean, this is all about doing what you're supposed to do. Surgical planning, this is all about expectations before and after. We go through all of those things. Jackie and her team members, we require that all of our replacements go to a joint replacement class. This is a one-time class for 90 minutes on a Friday? Wednesday. Dang it. It used to be Friday. So it's on a Wednesday, it's 90 minutes, but I think this is the time when you get all your questions answered. You're going to talk to therapy, you're going to talk to home health, you're going to talk to the nursing staff, you're going to talk to case management, you're going to get all these things answered and prepared before we even do surgery, so that when you do have surgery, just recover. We don't have to bother you with the other things. And I think that that's really helped. Again, just prehab is as important as post-hab, meaning if the better you are before surgery, the better you're going to be after surgery. And so I'm going to talk about this in a second, but now we're starting to implement some different things where we're checking up on you 30 days before surgery. Hey, did you do your exercise today? Here's your video. Pop it up, show the app. Here's the thing. This is going to tell you what exercise to do, so we can get you there before you even do it. And then afterwards, for 16 weeks afterwards, here's your exercises of the day. If you have questions, you can text us and stuff like that. So it's pretty cool things if you're tech savvy. If you're not, it's okay. We'll make fun of you, but that's fine. So that's kind of the talk for the hip, and I'm here to answer questions. I didn't want to talk too long because I want to answer questions about the anterior hip replacement. But these are some really cool things that we are now doing at the hospital. I think there's going to be a huge push for this remote therapeutic monitoring, right? And even Medicare and Medicaid is starting to reimburse hospitals and physicians based on, are you doing this or not? If you're not going to get paid the full amount. If you are, you're going to get paid. Again, this is not why we do it. I'm a nerd at heart. I think this stuff is really cool. So what we've started doing, actually we just opened up this program about 3 weeks ago. This is called My Mobility. It works with your smartphone or your watch. And basically what it does is if you decide to have a hip replacement, we enroll you. And basically what it does is 30 days before your surgery and 16 weeks after your surgery, every day it'll text you, here are your exercises, and you click on the exercise and it'll show you a little video. Here's how you do that exercise. And it'll say, remember to take your aspirin at 8 and 8. Remember to take your antibiotic. It prompts you all these things and it just helps you. And if you have your phone in your pocket, it can tell me how you're doing. It can monitor how you're doing. How many steps have you taken? How, and if after surgery, day 13, all of a sudden your steps went from 2,000 to 1,000, on this computer screen that I check every day, I have a red check on you and it says, so then my staff can say, hey, everything okay? Are you okay? Can we check on you? More importantly, you don't like what your incision looks like. Take a picture, securely send it to me through this program. I can look at it, answer questions in live time, save you a visit, save you from having to sit in my office and wait for us to say, yeah, it's fine. So just a lot of cool things. We're doing this for hips and knees, and I haven't started doing it on shoulders, but I'm eventually going to do it with my shoulder replacements as well. And then this is a different topic, but this is, man, this is really cool. So I'm starting to do this as well. This is called Persona IQ. Basically, this is a knee replacement that we use this robot to do. But on the bottom of this knee replacement, this little piece right here, we add it to the bottom, and there's a gyroscope inside there, and it literally can tell me your steps, your range of motion, your activity, if there's any instability, all these cool things. Now, first question everyone has, no, there's no GPS tracker in this thing. Trust me, I don't care where you are, right? But everyone asks, can I be tracked by the government? I'm like, you can. It's called your cell phone. It's not this, right? So this is really neat, and I think this is going to be really cool, again, just to give me an idea of how your recovery is doing, what's your range of motion, and we can access this at any time we want through a platform. So just cool things that are coming and that we're doing now. So, and then just this, I think, the team approach, I think you're only as good as your help, right? And so if you have a family member, if they're not getting rest, or they're not getting a break, they're not going to be as good to you either, and I think we harp on this as well. You need a team. When I do a replacement, I tell people you cannot be by yourself for 5 days. You need someone with you for 5 days. After 5 days, you just need to have a cell phone and someone that can check on you or that you can call if something's going on. So I think that's really important. But, and then, yeah, oh, the other reason that I like the anterior hip replacement is truly, after we do the replacement, I tell you to just go. I don't have restrictions, right? I'm not putting a pillow between your legs. I don't care if you cross your legs. Now, there are certain things that you're not going to do. I'm still going to say, hey, don't kneel. Don't pick anything up yet. Don't squat. I don't want you doing those things. Can you? Sure. Should you? I wouldn't. But truly, I want you to get back to your normal lifestyle as soon as you can. And that's one of the main advantages with the anterior hip replacement. Thanks, guys. I appreciate it.